Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
So I would like to introduce Dr. Valerie Krupnik, who works as a psychotherapist at the Naval Hospital Camp Pendleton. His patients are active duty military personnel, and his main interest has been in the therapy of depressive and trauma-related disorders, which is reflected in his scholarly publications and conference presentations. More recently, Dr. Krupnik has become interested and fascinated by a relatively novel and very influential theory of predictive processing and active inference. And as a result, he has come to the approach of psychotherapy, including the Therapeutic Alliance, in part through the lens of this theory. Other components of the theoretical basis of his work include evolutionary and stress theories, which is what he calls his theoretical creed of IESP, which is Integrative Evolutionary Stress Predictive Processing Theory. He has a Master's of Science and a PhD and a Master's in Social Work, and he's a licensed clinical social worker. Opinions and conclusions expressed herein, as well as anything in the podcasts, are his own, and they do not reflect the hospital or the military's policies, regulations, or guidelines. So with that being said, Dr. Krupnik, I am very excited to have this conversation with you. And if you could take a moment, tell us a little bit about yourself. The main objective for the podcast here is to discuss the manuscript that has caught our attention, which is titled Therapeutic Alliance as Active Inference, the Role of Trust and Self-Efficacy. Welcome to the podcast.
Okay, thank you for having me here. I just want to clarify certain things, so I will briefly outline my professional experience. I started off studying biology, and this is where my master's and PhD degrees are coming from, and always been interested in psychology. But as you can hear, my accent comes from Russia, and at the time of my higher education, psychology was in shambles there, and I chose biology as the second best thing. But once I moved to the US, I decided to slowly but surely make my way back to my interest, and I completed a school of social work so that I could become a psychotherapist. I have been practicing for quite a while now and have settled in this field of psychology.
The settling in your psychology primarily focuses on depression and post-traumatic stress disorder. Is that correct?
I joined the hospital when there were two major military commitments still going, both in Iraq and Afghanistan, and post-traumatic stress disorder was in the forefront. This is also reflected in my publications because initially it started mostly focusing on depression, and then trauma-related issues also were added.
So thank you for the clarifications. And then getting back to the publication of interest here, the manuscript about therapeutic alliance and active inference is intriguing to us as physical therapists because there is a move to try to understand the development and the persistence of chronic pain. And within that move, there's an argument to be made about the importance of predictive processing and active inference, which might be a process that occurs in those with chronic pain as they try to avoid the things that they would predict are going to create levels of pain. And the avoidance behaviors, of course, end up perpetuating the chronic pain. But with that being said, the first question I would have for you is, how do you begin to conceptualize predictive processing and active inference as a component to the therapeutic alliance?
I came to think about active inference as it relates to alliance is seeing it interaction of two models, two generative models. When two people interact or more people interact, they have to have a certain model of whom they're interacting with. How well these two models align, in my opinion, will determine the strengths and the dynamics.
And then with active inference in the therapeutic alliance is really reflective of the social interactions that individuals have. Do I understand that correctly?
Yes, because from the literature we have so far, and I'm not sure about physical therapy, but from the standpoint of psychotherapy, we have a pretty solid literature that alliance is a key to the outcome.
Well, we've certainly come to understand that as well in physical therapy. That's how we ended up reviewing your manuscript. And then along the lines of predictive processing and active inference, there's a suggestion of the free energy principle. So my question for you then is, what role does energy efficiency have in the therapeutic process and recovery? And I guess another way of framing this question would be, is the predictive processing and active inferencing that occurs within the therapeutic alliance, does that help to gain more efficiency in the interactions between you and your client? And does it help to provide insight into your patient as to how they can become more efficient in the processing of their challenges, whether they're psychological, mental, or physical, or a combination of all of those?
The way I look at it is when a client comes to therapy, they come because they cannot figure it out on themselves. So if it's pain, it's pretty obvious they cannot figure out how to make it go away. If it's emotional pain, it's exactly the same story. They want to get rid of their emotional pain, but they don't know how. So they need help in learning how. And that, from the standpoint of the free energy principle, means that they failing to decrease their free energy. Or kind of a friendlier way to talk about it is to decrease their sensory surprise, to let us know that something goes wrong. So it's specifically designed to surprise us. And when we're failing to decrease that surprise and alleviate the pain, it means that we're failing to balance our energy in an optimal way. And then we go to therapy to have someone help us. And as far as the therapeutic alliance goes, this is the very first step to help the client to rebalance this energy.
Yeah, that's very interesting. So the idea they're gaining energy efficiency starts with the therapeutic alliance that gives them a sense of trust in the reflections that they might be seeing through you as their therapist. I think that does parallel the way physical therapy interact with their patients.
I think it does because there is a way that we deal, especially with heavily traumatized or veterans, regarding their physical pain. Because when they come to psychotherapy and physical therapy, one thing that people thought initially would be, well, massage can be helpful. The problem with that is that they cannot take massage. Any touch to their body causes them emotional and physical pain, and they highly mistrust any touch. Sometimes they mistrust the touch of their children. So I do believe these things about energy balance and trust cross over from physical therapy to psychotherapy or vice versa.
And that makes perfect sense. Thank you for clarifying. Now, with that being said, one thing I've noticed with my patients, and part of the academic work I've done as well, is that people in chronic pain have a distorted sense of self in their body. And it seems like you mentioned that as well in your manuscript. Could you take a moment and explain the concept of the pathological distortions of self? And how do you initiate the self actualization into the recovery process of that? There must be a strong similarity in those distortions of self.
So starting with your question about distortion of self, when the predictive process is not working correctly, people lose sense of self. They start doubting. Pretty often my clients, especially those who have anxiety issues, they come and say, I can't sleep because my brain just wouldn't stop. So it's a very benign example of self-distortion because your brain and my brain are part of us, so they don't do anything on their own. It feels to us like they do. So this is kind of a small self-distortion. Now, when you first invited me to this podcast, I got an idea about pain, and I'm not sure if just a new idea or somebody has figured that out before me, because physical pain is not my passion. But my idea about that was that when people have acute pain, their expectation is that they should be painless. Now, when the pain becomes chronic, the model flips over on its head because the pain has been there for so long. People start expecting pain. And this presents a problem with treating chronic pain because if we take it from the standpoint of active inference, if you have an expectation of aching body, your body will be aching. You will be perceiving any sensation coming from your body as pain and as excruciating pain because this is your model. And your mind will overlook any instances when you're going pain-free. For example, with my patients, I pretty often see patients who present with physical pain as well. And I often hear they say, I'm constantly in pain. And I can clearly see this is not true because when they engage in the conversation with me, I can see that they're not in pain. I don't think they are trying to deceive me. It's just how their mind works. In treating chronic pain, it's very important to treat the mind in addition to the body.
And what I hear you saying with that last statement is that in treating the mind, you are treating their sense of self to a new reality.
Yes, in a way. In a way, it may be the case, at least for some of them, because if somebody has a little bit distorted sense of self, it is inevitable that their anxiety will go up because their whole existence will be very surprising to them.
Well, that's fascinating. We circle back to the commentary about people losing their sleep. And if I heard you correctly, the indication was that their loss of sleep was reflective of or a distortion of the self. Is that correct? Did I hear that correctly?
Yes, to clarify, if you want to sleep, you may want to have some assurance that you are capable of sleeping just like any normal person in the world. However, if your sense of self is perturbed in some way, that trust is undermined. You become less sure.
So I hear you relating it to anxiety as well. And that's the second part of my question is would that not relate to the predictive processing in that there are aspects of their life they're trying to figure out. And in that process of figuring it out and trying to establish a process and establish a duration for their problem to resolve, that their mind doesn't shut down. And therefore, it creates this circular anxiety pattern that also keeps somebody awake. And that seems to tie in self-efficacy.
Yes, it is tied to self-efficacy. This is exactly true. And this is why in my paper I tied together therapeutic alliance, trust, and self-efficacy.
That's well said. How does mindfulness help in the reconceptualization of the self and the correction of predictive processing for an individual with either physical or emotional pain?
Well, this actually may not be as straightforward as it looks. I can give you an example, and by the way, this is an interesting point for me personally because it touches on the history how I got into the predictive processing thing to begin with. I had a patient who had PTSD and also functional movement disorder, neurological functional disorder, where he had a kind of tic. I didn't know what to do with him. I started doing my homework. I did some research and came upon a paper called Predictive Processing Account of Hysteria. And then I started looking into predictive processing part, how predictive processing explains functional neurological disorder. And then coming back to what you were asking about the role of mindfulness, I do believe it plays a significant role, but it has to be used in a very specific way because we always need to shift our attention from ourselves to what we're doing. Therefore, mindfulness is mostly practiced in general as a way to get people away from their executive mode to the mindfulness mode. So if we speak about it in neurological terms, we want to shut off their executive network and activate their default mode. The ultimate goal is not just to train people in mindfulness, but to train them in the capacity to switch at will. The stronger their self of sense is, the stronger our alliance becomes. And this is my goal.
Fascinating. I tend to use mindfulness with my patients for a couple reasons, and let me know if this resonates with you. One of the reasons is to find some acceptance with the state of being as it is in that moment.
Mhm.
Another reason is to have them shut down the executive function, though I'd have to admit I've never really thought about it that way. More so just to have them recognize that the thought processes that they have aren't necessarily part of the experience that they're having, and or they are a distortion of the experience that they're having, if that's what they're paying attention to. In other words, their focus on their thoughts is actually robbing them of the experience that they could be having. And I find that in the process of having them shut those thoughts down, they also shut down the hyperactive nervous system, and the focuses that they've had, which most of the time is pain, then tend to shift. And they can actually shift away from the pain, which I imagine, again, is very similar to what you've indicated in part of the conversation already.
Yes, it's very interesting what you're saying because the way I'm seeing it is exactly how you put it. As I imagine to be in a physical therapy office, and if a physical therapist wants to help me increase the range of motion of my shoulder, the first thing that comes to my mind is it's gonna be pain because I know. And as long as I focus on that, and as long as I believe that, I'm not gonna trust my physical therapist. Then the task at hand is twofold. One is let me trust my therapist, and two, related to trust myself.
Yeah, I mean, that's a nice way of emphasizing the importance of therapeutic alliance. So, Dr. Krupnik, that allows me to ask the next question. How do you teach these concepts and principles to your patients?
I do it in a very oblique way, and I will explain why I prefer to doing it this way. I'm doing it by mentioning and focusing their attention on a lot of things that they tell me are not actually happening. It's their expectations or assumptions or predictions, whatever they want to call them. For example, if the patient is in my office and he tells me about how angry he is, I'm reminding them that there is nothing to be angry about unless they're angry with me, because there are only two people in the room. So this is an oblique way to let them know that what's happening is their model of the world is laying itself out rather than the reality getting to them. The reason I don't want to go into nitty-gritty of all these abstract things is that I prefer this process to be not transparent. And the reason for it is that it may interfere. For example, certain things are better done under the level of consciousness. For example, if we go back to the issue of mindfulness, too much mindfulness may be detrimental. If we were able to be conscious of every single process going on in our body, we would have been paralyzed. We would have been completely overwhelmed. If you could hear everything that your nerves are doing in your body, it would have driven us completely crazy. For the same reason, I don't want too much of this process to be in the focus of attention.
I'm interpreting a lot of what you're saying as a genuine approach to the human interaction. As you mentioned previously with a therapeutic alliance and the predictive processing and active inference, we know that happens organically anytime we're in a room with somebody else. But it isn't something that we have to discuss that's happening in order for us to still communicate at some level and share the experience at some moment.
Yes, and that actually brings us to a pretty simple bottom line here, which is if you want to build a strong, healthy alliance, being authentic is very important.
That's well said. And what I hear you saying, you're looking beyond the surface level. You're seeing the individual in front of you. And they're seeing somewhat of a reflection of themselves, but they're seeing somebody authentically presenting themselves willing to help.
Yes, and by the way, seeing yourself is not enough, because if it were enough, you could look in the mirror. What they want to see to build trust is to see themselves in somebody who's not themselves. That creates some level of trust in themselves. Again, this may sound counterintuitive, but one of the ideas I have in my paper is a certain level of trust, which is self-trust. For example, as we talk, for me to trust you, I need to know that I can trust myself enough.
Beautifully put. A lot of us in physical therapy and those who have been in chronic pain have experienced a fractured therapeutic alliance, if there ever was one, with the healthcare system. And many of the patients are very distrusting. They're very angry, which I think a lot of times masks a level of depression. But my question then becomes those patients who are enduring chronic pain and or depression, how would you manage that level of prior experience that had occurred within the healthcare system that increased their likelihood of uncertainty, which I imagine really means that the predictive processing automatically implies that they shouldn't trust anyone.
Yes, indeed, and it's something block because I can see it in my practice all the time. And not to discourage you, but on a weekly basis, I hear people say, "Went to physical therapy 5 times, was completely useless. Then I went another time, and I don't even bother anymore." And yes, I agree. The next time they're gonna go to a physical therapy, they're gonna go with exact same attitude, which will come true because this is their model, self-fulfilling prophecy. We in psychotherapy deal with that as well. Maybe not in such a stark way, but we still deal. I do have people come to me say, okay, I did have therapy 2 years ago, 3 years ago, and I'm still feeling sick. Now, what can you do with that? It's hard to know the right recipe, but as I'm validating the state of mind, I'm basically confirming their model. So I don't try to disprove them because for once it will most likely be counterproductive. Instead, I'm trying to do this kind of roundabout way and I try to first confirm their model. Okay, you're right, your experience has been bad and I'm not giving you any guarantee that it's going to be different right now. I can't promise you anything, but one and only thing that I'm going to try my best.
It seems like our disciplines are very different and yet very similar, and we share the same frustration that we see with the healthcare system. We have to try to get them better as quickly as possible, and many of these situations have a behavioral component and a psychosocial and spiritual component that require months to years of intervention for true change to occur. And we could only hope, I think, in most cases, with the way insurance dictates therapy and the mandate mandates that we have with the therapy, specifically physical therapy, that we can get the ball rolling. But I think we're both working for the same thing, which is to empower the patient. And again, I think that reflects
Hmm.
a certain timeline or a certain extension of time that goes way beyond what's allotted by insurance companies. With that being said, I did want to talk about empowering the patient, which is, by the way, is how I came across your paper. I'm currently writing a manuscript on empowerment and the undercurrent that helps establish empowerment. Concepts like suffering, self-efficacy, resilience, of course, therapeutic alliance, trust, communication. One of the things that I found in the literature reviews that I've been doing is that self-efficacy seems to be a prerequisite for empowerment. Specifically, if we talk about suffering, the suffering can be the weight or burden that brings somebody down into the depths of major depressive disorders, but it can also be the fuel that allows somebody the trajectory to find a way out of that. And the switch that occurs between those two paradigms, a suggestion that we're making to say that that's empowerment, whereas self-efficacy might actually be the confidence to employ the different techniques that would allow you to move in the direction of reconstructing yourself and utilizing the suffering as the fuel to help you reconstruct yourself. I see self-efficacy as a mediator to change and then the empowerment to follow through with that change. But again, I mean, this is all abstract and philosophical in nature right now. I'm trying to give it some legs. Your paper certainly has helped that, right? But the importance of trust, you mentioned epistemic trust and the importance of self-efficacy and the importance of the self-attenuation. Hopefully you and I can talk one day in the future and find out whether that was right or wrong.
Yeah, it may not be either, because the way you talk about empowerment, I see it as kind of a high level belief that you are empowered somehow, whether it's through spiritual beliefs or personal development, whatever the case may be, that you are empowered to withstand whatever comes your way. Basically, it's a self model. When we talk about predictive processing and models of the world, there is also self-model, how you see yourself. And I believe that empowerment may be part of one way, as you said, when people are in deep depression and despair, sometimes they believe they can't even move. They start to believe that, well, no matter the suffering, they still can forge on. And yes, I agree, it's a philosophical question.
I like the way you've tied that all together. So, Valerie, you mentioned being authentic. That's a concept that resonates with me very deeply. And along those lines, some of my colleagues and I contemplate the difference between empathy and compassion and the authentic presentation of those. I do have a final question here for you. How do you reconcile those differences between empathy and compassion framed within the context of the therapeutic alliance?
To me, actually, this is not a very big challenge at all, because maybe because of the training. We psychotherapists pretty much all are trained in differentiating these two concepts. And you can be empathetic with someone for whom you have no compassion. And yet you still can work with them. You can empathize with their side of, with their world view. You can feel how they feel about the world. You don't have to sign up for it, but you can understand it. And then you can be compassionate with people without empathy. You can be compassionate with a suffering animal without understanding much of the animal's state of mind. The harder question here is what do you do when you can't help feeling compassion for your patient? And this is something that, at least for us in psychotherapy, we have to navigate very smartly, because if our compassion kind of transpires and comes through in a strong way, it can be counterproductive therapy. Because when a patient comes to us, they have a certain model of us as people who are, as you say, empowered somehow by their titles, those letters and their credentials, whatever their certificates, what they see on the wall. And they want that empower. If they see compassion and if they see it as, it can be overwhelming for them. They can feel that they are stepping into as much uncertainty as they had before they came in the therapist's office. So for us, we have to hold it back pretty well. Sometimes we can let it transpire if we have a really good alliance and we're pretty confident that it's not going to overwhelm the patient. But we are trained to keep these two things separate and use them very judiciously.
Once again, well said. How can healthcare start to utilize your conceptualization and modeling of therapeutic alliance?
First off, it would be good if the healthcare system take it seriously to begin with. But if you look about the general phrasing of their guidelines and the way they want us to frame our treatment plans, it's all about measurable goals and symptoms. Therapeutic alliance is not a symptom. It's not that easy to measure therapeutic alliance in every session. It's a very dynamic and fluid thing, and it goes up and down, and we will also have a lot of evidence for that. And having some allowance for building an alliance and having it as a serious goal in treatment would be a good first step.
I've been screaming that from the rooftops and mountaintops since I can remember. The evidence suggests what we've already discussed. The outcome, which is what healthcare seems to be basing all of their current guidelines and mandates on, is directly tied to the therapeutic alliance that's established within the first visit and then built upon in a fluid manner throughout the episode of care. But yet, you're right, the needle hasn't moved in any way. As a matter of fact, it's probably moved in the opposite direction.
Yes, it probably has because there is fiscal incentive to move it away from the alliance. But especially speaking to what you deal with, chronic pain, it's just hard for me to imagine how it can be helped without a good trust in the alliance.
I concur. Is there anything else that you think would be important to relate?
The latest trend to use psychedelics for psychotherapy. I'm not sure if psychedelics have already found their way into physical therapy, specifically chronic pain. That could be one more direction.
That's fascinating. I have an introductory knowledge to the psychedelics and how they've been used for major depressive disorders and PTSD. I'm looking forward to more research on that, but what has been done so far is strong and should point us in that direction. I would love to see that carry over to some of the chronic pain patients. Along those lines, I have discovered with some of the work I've done in self-efficacy and with chronic pain that there's common threads between those who are in chronic pain, those who are struggling, enduring depressive disorders, and those who are struggling and enduring substance abuse disorders. And the issue is compromised self-efficacy and self-regulation, which I think touches on part of the conversation that we started with, the idea of a sense of self and the inability to regulate that sense of self with the perceptions associated with predictive processing. So I imagine that there are individuals, particularly after the opioid crisis, who have now been disregarded by the healthcare system, have gone on to heroin as the mechanism to manage their pain. So they have a substance abuse issue and are majorly depressed. I would imagine that psychedelics would be appropriate for them at some point.
Yes, and that brings another idea here that to do all that, it's necessary that people from different fields interact because otherwise it's impossible to make progress. So, pharmacological people, chronic pain people, psychotherapists, people dealing with interpersonal relationships, they need to come together to use and to develop those approaches.
I couldn't agree more. So, Valerie, are there any other resources that you would like to mention for physical therapists?
The special issue in Frontiers 2023 may be of interest to physical therapists on therapeutic alliance and active inference.
I will definitely put that in the show links. Well, this has been a very special conversation to me. We have a lot in common, so I've enjoyed the conversation. Thank you very much, Dr. Krupnik, for all your time.
No, thank you. Thank you for the opportunity.
Beautiful.
I enjoyed it as well.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.